So, afternoon everyone, and a pleasure again. This is my first session at JPEF 2024. Always a pleasure to be at this wonderful place amongst wonderful hosts and people. So, what we're trying to do here, so I've changed my topic, but it's absolutely open. What Dr. Jyoti told us and Amit Rakesh, and we thought that we'll play it to the gallery. Let us do what, as it's a workshop, what you all really are interested in. So, can we see some show of hands? What really do you want? It's a session on CGM. It's part of the CGM Academy. We don't necessarily need to make it very theoretical. Rakesh told us about the nuts and bolts, introduced us to the concept of CGM and certain finer nuances. Should I go ahead and speak on interpretation of AGP, or is everyone really aware of how to interpret the AGP, which is the software report that you get from CGMs today? That is AGP, ambulatory glucose profile. Is that what we should do? Would people be interested in looking at, or everybody knows how to interpret AGP?
Almost.
How many of you know how to interpret AGP absolutely well? So, I see one hand raised and one modest Dr. Jyoti there saying that he also knows it. Okay, so let's start with this and I'll take it from there. So what I'm trying to do is show some aspect here and show the connected CGMs. How is work happening from Dr. Jyoti Dev's center and many of us? How are we staying connected with our patients because of connected CGM and seeing their data almost live as required? So these are my disclosures, but my want is below, and hopefully that happens really soon. So of course, theoretically, why do we want to monitor? Because A1C doesn't give us the large picture, and that's why we need the CGM. How do we make best use of the CGM? Life's been made easier today with the concept of time and range. I'm also trying to avoid some conflict of slides and show, because soon after this one, I'm speaking in the session, the hall down, on how to really reach FNIR, flat, narrow and in range. So I would invite all of you, post this session, those who are interested to know exactly more, we'll take it down to the other session. So how to effectively use the CGM data is by AGP. So as I said, now AGP is not owned by ADC or the Libre makers. It's a software licensed from IDC, Minnesota. Anybody can pay the money and take this software, any company's product. So today a lot of other CGM companies and others are licensing this product and using that software to apply to their data. What is important is if you look at just CGM data, every day can have a different line. And when you get the report like we used to do earlier, it was extremely difficult to interpret in some patients because there was too much of variability. So that's where came in AGP, which is a software derivation that all the day's reports, it will show you into a 24-hour profile, which is a percentile-based derivation. Also, contrary to what we may think, AGP is not confined only to 14 days. It takes minimum 5 days of data to form an AGP report, but you can get the AGP for even up to data of last 90 days. Again, it could be much longer than you put in and you'll be able to get the data. Hopefully, things get clearer. So this is how you would get the data in the past, right? You would get data in this aspect. How do I interpret? Your patient is spending money, and then what do you do? So that's where came in the aspect of percentile derivation of software, which is based on the median line, which has 50% of the data, the intertertile range, which has almost 75% of the data, and the last two extremes, which is 10 percentile of data up and down, which includes in the interdocile range. So that's why data density brings its own problem. How to interpret this, what to tell the patient what's happening. And that's where came in AGP, which is a derivation. So let's understand the AGP curves. Right, as I said, the median is where the 50% of the data lies. Between the 25th and 75th percentile is the interquartile range. And the extreme shaded portion from top to down is the interdocile range. Now, what we need to remember is when we see the report, and very often when you start seeing, you'll have just a half a minute at the most to interpret. Everybody has busy practice. Start looking at the center line. That's the median. That's most important. And look from the left to right. So you know from 12 a.m. to 12 a.m., 24 hours, how is the sugar moving. Also, let's understand that though this is represented in 24 hours, it's data over many days. So it's all compiled and given it to you in a 24-hour profile. After you've seen the median and the movement, then you see the other line, which is within that 75% data, because that's where your medications come in. When you find that how the AGP is either narrower or broader, where is the movement, you decide what to do with the therapy. And then the light shaded portion, which means that this has happened only 10% of the times in that period, which is usually related more to the individual's lifestyle, whether it was lack of exercise or more exercise on one day, it was wrong eating or less eating. So that variability, which was less often during that period, is reflected in the shaded portions up and down. So you watch that, and that's where you will tell the patient that, on certain day, when you see the individual day data, that you probably ate late or you had that extra midnight snack, and see how your sugars went up. But you don't change the therapy based on the variability of top and down shaded portion, but essentially you do it on the basis of median and this blue shaded portion from 75th to the 25th percentile. So the graph is a modal day. Let me run through the theoretical part. What you also get in these reports is telling you that where is the possibility of low sugar. Based on the variability, you are able to identify the danger zones in a 24-hour period. For that particular patient, is it the lunchtime, is it post-dinner, where are really the excursions happening, which allows the physician to guide the patient better. Of course, a lot of these reports were based on the professional CGM, which is still used, and then you have reports coming out of the personal use CGM, which we have to teach the patient to interpret. They are spending money, but they are not using that data much. So you'll have people who buy the iPhone 15s and the Samsung Galaxy S24 and using it only to call without the features. It's a waste of money. They should know how to use that. By the way, somebody knows more about phones can teach me how to use the phone properly also. So time and range in context with AGP report. So then in the report, the next page, you start getting the individual day. First we showed you the combined AGP profile, and then you start going and see the individual day report for the patient. And it's important because sometimes you may see in the AGP that you're not identifying any curve going below 70, no hypoglycemia. But then you go to the individual day report and you see 2 or 3 days the sugar has dipped to 65. So why it's not coming in the AGP? Because as I said, AGP is a percentile derivation. It will knock off the up top 10% and the low 10% data. So if that hypoglycemia was not repeated or not for significant amount of time, it will not come in the AGP. And which is why seeing the each single day data becomes important. Also, when you see the single day data, you get the time in range metrics for each individual day, and towards the end of the report you will get it for the whole duration of the CGM. So this is what normal would look like, right? And then you have what would be a good control in diabetes. This would be good. It's largely within your 70 to 180. You're not seeing too much of inter-day variability or intra-day variability. And that's another important aspect. What is inter-day variability? How the sugars are changing from day to day. So if you look at say 12 o'clock in the afternoon, you identify that, 12 o'clock. So is the sugar very different between 12 o'clock up and down? Not really, it's within some 30-40 points. So if somebody is really going up and down, that means that there is too much of, if the AGP graph rather is broader, that means that the person is varying from day to day. So that is inter-day variability. And the second thing that you see is the intra-day. That means what is happening in a 24-hour period. For this individual, it's pretty flat. But somebody who's is normal in the morning, post-breakfast, jumps to 300, then comes down to again 85 before lunch, goes up, that is intra-day variability. So what for years we never realized was the glucose movement. Right? We continued to manage diabetes just by looking at some bare numbers. One fasting postprandial, maybe one HbA1c, which also people will say that across the country for cost issues, not every patient does HbA1c. So how do you manage diabetes? You manage on one fasting PP from the laboratory, you manage on some SMBG, but we were missing the point. Sometimes we have sat back and thought that this patient saw me for last 15 years and seemed to be under good control. But today he's landed up in stage 3 CKD, his eyes are almost gone, he has peripheral neuropathy. What went wrong? It's because we didn't know the impact that variability can have. somebody who's constantly at 150 to 180 is actually better off than somebody who's going from 70 to 300 within the day on a regular basis. So is this good control too? That's my question to you. Right? Well, obviously no. You can see that there are zones of hypoglycemia and hyperglycemic excursion. So when we talk about something like this, that means there's a lot of inter-day variability. Look again at 9 o'clock. On 9 o'clock, within this period, the sugars have gone from 70 to almost 300 on different days. So this is a lot of inter-day variability. That means that the breakfast could be different on different days and hence the sugars are rising. And also when you look at the intra-day in this, there are spikes, it's not flat. So there is a lot of intra-day variability also. And then the things to see is exposure, variability, stability. So what I'm going to do is show you one slide which kind of makes it easier to understand what really should be our target using AGP, and then I want to quickly show you the connected CGMs. So this is the movement of sugars that you're trying to track through the median. So what is it that you want to see? Now when you have sugars which are in this format, you want to see how much is the exposure. So going above the range, all the pyramids that you see is the sugars rising above the 180, 200 mark. This is all high, and then you're seeing some inverted pyramids going below the 70, which is hypoglycemia range also. So how do you really treat? Now when your patient has a profile like this, right, I can see that the patient's sugars are at 350, 400. A simple question to any of you. Based on this report, shall I go ahead and increase the dose of insulin or tablets because this patient is touching 350 and above? Should that be my approach for such a patient? Come on, somebody help me out. You're looking at such severe hyperglycemia. Shall we not increase the dose of medicine or insulin or whatever? No? Yes. Okay. So one aspect clearly that you would have thought is, yes, and then this kind of a patient, if you do an HbA1c, is more likelihood will have an A1C around 10% or so. So somebody comes to you with one fasting report, which is, let's say at 8 o'clock, that sugar was about 170, 180, comes to you with a 2 hours post lunch, which is in the 250 range. 170, 250, A1C 10%. You'll obviously go ahead and increase the medication and guide patient on the proper, walking diet. But you do that and the patient starts getting worse. Why? Because we missed the point there. So your priority when you see a profile like this, of course first do a CGM and see the profile for as many patients as you can. And when you identify this, your first principle is that you want to change the exposure here. So you want to reduce the variability. And when I say variability, it refers to the day-to-day variability. So you will make lifestyle and therapeutic changes, which can be any, to try and change this breadth of the graph, which is so broad. You want to try and make it narrower. That means the person is not varying at the same time from day to day. So reduce the variability, right, and try and bring it down as much as possible.
It can be because of non-compliance to medicine also. The patient may not be sensible.
So yes, it can be. So it can be non-compliance to medicines all the days. The patient is skipping medications at breakfast time or missing out. Yes. So you will dwell into medication, diet, all those aspects.
Injection time and technique.
Injection time, injection technique, all of that. In fact, so often we've seen for many patients here that before they reach into the breakfast time, the sugar is 200. Why? Because they took their cup of tea and 2 Marie biscuits or whatever at 7:38, and traditionally none of us have given medicine with tea and biscuits. We always wanted to give it at breakfast. But by the time they're getting into breakfast, the sugar is 190 and then they eat and it goes to 260. So is it wrong then for me to tell the patient that look here, you either take one of your medications, could be insulin, could be an A-cargos, could be a DPP-4, start taking it with your tea and biscuit and the other medicine with breakfast. Try that and you see a lot better profile. So principally you will first reduce the variability and then improve stability. Stability refers to your movement through the day within a 24-hour period, right? Chairpersons, I'll take 2 more minutes of Amit's time, right? So, which is where you're trying to improve the stability. So first you try and narrow it down, that means reduce variability, and then improve stability. That means if there is movement spiking going up at breakfast time or dinner time, again look into the factors, and it could be multiple factors as so many experts here pointed out. So you improve the stability. So see how the graph is changing and emerging, right? I will go back and show. So this was your original graph. You try to reduce the variability, that means the breadth of the graph. You're trying to improve the stability, means you're trying to get it more flatter. And only once you kind of achieve this, move to step number 3, which is reducing the exposure. And then only you're going to try and increase the medication dose to bring the whole profile down. If I would have tried to reduce the exposure, that means I was more worried about the 350 before doing other things. This patient who was already experiencing hypoglycemia would have had more severe episodes of hypoglycemia in the night. So again, remember the mantras: reduce variability, improve stability, and reduce the exposure. This is what you will do so that your patient gets into this profile, right? There's a lot more to this AGP understanding. As I said, I'll continue a bit of it down, but what I'll skip and do is take you onto the live mode. So I'm getting now into the connected system. So this is based on current Wi-Fi and connectivity, and hope that is good. You'll have to pardon that we're not able to hide the names, which is fine. So let me take an example. So all these patients remain connected with us. Let me choose one which I remember is doing it more continuously. So this is how your dashboard would look at your clinic or on your laptop. We can do it from anywhere and do this consult also. I'm getting into this profile and I'm seeing, so this is 13 July, that means this patient is currently using the CGM and I can see the data. So I'm pressing on the glucose reports and the LibreView will generate the current data for me. And this is the data. You can see the date, the sensor is, this data is from 30th June till today, is 13 July. What do we see for this individual? She's doing well. What are you interpreting in the report? Well, so the target range, which was 70 to 180, she's doing 85%, which is wonderful. There's no low, and she's doing 15% in the above 180 zone, nothing beyond 250. So I would say she's doing extremely well. She's as per target doing well. What also you see is the GMI, which is in the old reports it used to be estimated A1C. So the wrong name, GMI is glucose management indicator, gives you an idea of where close to the HbA1c would be, but it is not HbA1c. So you have to do the actual HbA1c separately. But this is telling you that this patient is headed to a sub 7 A1c. Right? And then the third thing you look at is the glucose variability. What the reports use is the percentage coefficient of variation, which is one of the most accepted metrics for GB. You had old ones, you had MAGE, MOD, standard deviation. CV comes from standard deviation and is more standardized. And the mark there is, for somebody to have, the recommendation is a good GB is less than 36%. But I will stand here and tell you today that that's not good enough. The GB, the CV needs to go down to less than 30% for most patients in India at least to reach the target. So the international recommendation is 36. You come down and you see the AGP profile. Right? So there is one, what do you see here? Is she too variable from day to day? Yes, no? No, right? So you've seen, you're looking at the thin snake moving from left to right. You'll see the up and down. There is some variability which is related to the diet. Is the patient still unstable? That means, is there intraday variability? There is some amount of intraday variability. And what about the in-range part? Largely the patient, as we showed earlier, is doing 85% in range, and then you can see the individual days and so back. I'll finish here by trying to get an earlier data from the same patient and see how, with the help of freestyle CGM and usage, has she evolved into seeing this profile. Let me see if I'm able to get an earlier data. But you're able to appreciate some of the profiles here. So look at this one. This was sometime in May, and you can clearly see that the patient's time in range was much lesser. The spikes at breakfast, lunch and dinner were high. At this point she would have been probably doing, and there were some hypo events as well. So see the variability. It's not that the drug has changed much for this patient, but purely by seeing how the sugars are behaving to different food and thing, she's been able to make changes and get herself to be better. This is even worse a profile in the month of April to May. So purely by use of repeated regular CGMs has she ensured that her profile has improved. So this kind of connected systems are now possible. So let me end here and hand it to, thank you.
Thank you, dear Manoj sir. Thanks a lot for throwing the light on how to interpret CGM, and thanks for sharing the